Hello, welcome to this NMC OSCE tutoring video. My name is Hannah. I am a UK registered nurse, a university lecturer in clinical education, and I've been an NMC OSCE programme lead. And I am sharing with you my advice and teaching to help you self-study and prepare for your OSCE exam. Also provide private, one-to-one independent OSCE tutoring. If you need that little bit of extra support with your OSCE preparation, please feel free to drop me a message on WhatsApp or on email. My details are at the end. I'm not as expensive as you think I might be, especially compared to some of the test centres and large training centres. Okay, so I'm going to continue with my little APIE series. I haven't done an APIE video for a while, so I've been really busy, and I'm going to look at the end of life scenario APIE. Again, this one can feel a little bit challenging, maybe not quite sure how to approach it, or how the patient's going to present. So I'm going to go through generally what the NMC scenario typically is. We're going to look at assessment priorities, we're going to look at potential care plans and the common medications that come up on that medication chart, as well as thinking about some of those recommendations in the evaluation part of your SBAR. Okay, so the end of life APIE for you adult NMC OSCE nurses is one of the 12 APIE scenarios. And like I said, it sometimes might feel a little bit unsure of how to approach this typical scenario and what you need to do for this end of life patient OSCE scenario. So just to start with an overview, so when we think about end-of-life care, it involves normally treatment and care and support for people who are thought to be in their last year of life. And the Marie Curie website, I've put the link on there, it's a really great source of information. Like if you want to read a little bit more around the work of Marie Curie, but also around end-of-life care and palliative care, and just increase your knowledge around that, and key things in terms of nursing care and for patients as well. And when we're thinking about end-of-life care, the aims are to help people live as comfortably as possible, in their remaining time. And it can involve obviously things such as managing physical symptoms. So we don't obviously stop treatment, but thinking about managing physical symptoms, these things such as pain, breathlessness, for example, obviously giving emotional support and spiritual care to that person and their family and friends, helping whether they need additional help with everyday tasks and activities of daily living, talking with that person about their needs and wishes, and helping them to talk with family and friends if needed. And also kind of supporting with getting practical support with things like wills and financial support. And again, that's all from the Marie Curie website, so it's a really good source. But if we're thinking about it in terms of our NMC OSCE, actually, we want to be prioritising those things such as managing physical symptoms and giving that emotional support and spiritual support and care as well in that holistic assessment. So the NMC scenario is typically a hospital-based scenario. So the patient has presented end of life care, so in that last 12 months of life, normally obviously with a cancer diagnosis, and they present actually with some acute abdominal pain secondary to constipation and some shortness of breath. And there's a history of having opioid analgesics for pain control. So that's the presentation. The patient is obviously alert and talking. And sometimes when I work with nurses, they think the end of life scenario, the patient's going to be at those very last days of life and, maybe not conscious and not talking, but they are, okay? So they are not at that stage of their condition, if that makes sense. So patient presents with abdomen pain, constipation, shortness of breath, and I think shortness of breath could actually be linked to that constipation. So when the bowel is very impacted, it splints up the diaphragm can't work as effectively, and that causes some shortness of breath. So you want to be thinking about linking those things together. And they might not be short of breath due to a primary kind of respiratory cause, such as like pneumonia or asthma, for example. So assessment priorities, so the NMC still require you to do the A2 assessment. That remains exactly the same. We just want to be obviously assessing pain and thinking about those analgesics which they're taking and the side effects of that. And we want to be assessing constipation if the patient's coming with abdominal pain and history of constipation, and what their normal bowel habit is, how long has it been since they've been and opened their bowels, thinking about that Bristol stool chart as well, and assessing using that Bristol stool chart would be something that we would verbalise doing. So those are your main physical assessment priorities with the scenario. You are still expected to complete and do the news too. And this is maybe a little bit of a controversial point because the news too is designed to pick up acute deterioration. But it is required in the end of life scenario exactly the same by the NMC. You are still required to calculate the score. You're still required to verbalise and document your monitoring frequency, and you're still required to do your escalation policy as per the news 2 charts. And that remains exactly the same as per the rest of your APIE scenarios. So going on to that holistic assessment then, we've obviously focused on pain, we've focused on that constipation, again, maybe assessing that shortness of breath as well. And then we want to go into kind of that, psychosocial aspect of our holistic assessment. So like I said at the beginning, it's really important that we focus on emotional support and providing that support and opportunity for the patient to talk. So we might want to address things such as, discussing their wishes for their care at home in the next 12 months. So, would they prefer to be nursed at home or in hospital? What support have they got? Have they got family support, partner support? Are they by themselves? Thinking about those, asking them about any worries or, that they've got anything they wish to talk about death and dying. And we can offer support to other palliative care and end-of-life nurses as well, so Marie Curie, and support charities as well, such as Macmillan Nurses. So a couple of things to think about there. Spiritual needs is really important as part of this, this end-of-life scenario, and having a terminus illness, often leads people to think about their lives in new ways, and their spiritual needs may change. Okay, so Marie Curie advocate that all health and social care professionals can help explore the patient's spiritual needs and identify when someone might need some more support. And they have this really nice acronym called HOPE. So H is for hope. So what are the sources of hope, strength, and comfort and peace? So what things do they really hold deeply as being comfort and provide strength to them, and how can we support those with that? O is organised religion. So do they have a religion or faith, and how important is religion to them? So it is important to ask about your spiritual needs in your holistic assessment here. It could impact a lot of things towards the in that end of life kind of scenario. So we need to be kind of aware of that and ask our patient. P is for personal spirituality and practices. So again, thinking about any personal spiritual beliefs. So that might be different to religion. So spiritual beliefs and religion are different. Okay. And again, finding out, if there's anything that's helpful or anything that they want support with. And then E is for effects on medical care and end-of-life issues. So, has their current condition and illness, stopped them from doing things that give their life meaning and purpose? And are there any specific practices that we should know about when we care for them? Okay, so that's a nice way to remember it. You might not have time to do a really in-depth spiritual assessment, but you definitely want to be picking up on some of those key issues. And part of this as well is around, and then obviously, moving on to that kind of sexual part of your holistic assessment, you can focus that around kind of family support. Who have they got that's supporting them? Do they want the family involved? Do you need to be contacting anyone as well? So just thinking about kind of that holistic assessment with them. So moving on to care planning. So the patient presents with constipation. So a really relevant and obvious care plan to write is one for constipation. And relatively straightforward, because if you are well into your OSCE study by now, you'll know that one of the clinical skill stations is the bowel assessment. And for that, you need to be able to write a care plan for constipation or some. So you can move a lot of that information over from that station and use it in this as well and just adapt it to your scenario. So, for example, the problem could be Craig has constipation due to not opening bowels for 5 days and experiencing symptoms of abdominal pain and difficulty passing stool, or something around those lines. Doesn't need to be exactly the same as that. Our aim would be for Craig to open their bowels daily, and we could bring in that Bristol stool chart there. So with a Bristol stool chart of 4 to 5, so that's kind of like a normal bowel motion. When would we reevaluate this? So we'd reevaluate this most probably every 24 hours. Or every time Craig goes to the toilet and passes stool. So interventions we could do with this then. So obviously our standard core interventions across our care plan. So we always need to explain the plan of care to the patient and gain consent. That's obviously a legal requirement. We're going to monitor and record news to vital signs as per guidelines. We're going to assess Craig for causes of constipation, so diet, fluid, medications. And in this case, we're most probably going to ask for a medication review because it could be those opioid analgesics. We are obviously going to assess Craig's bowel motions using the Bristol tool chart, so thinking about additional specific assessment tool for constipation here. And we might also going to assess bowel habits, so time, frequency, and if there's any pain on straining. We're going to administer prescribed laxative medications and obviously monitor for effectiveness. And obviously fluid input is really important in constipation. So we want to record fluid input and overall balance and promote an increased fluid intake if possible. We also want to try and increase fibre in the diet, including fruit and vegetables if tolerated. And we could provide some positive toilet habits, so things such as providing privacy, positioning, potential breathing exercises. We're always going to escalate if the clinical condition deteriorates or current treatment is not effective as well. So lots of points we can use there. And like I said, you can use those points in your bowel assessment clinical skills station if you get a constipated scenario as well. So learning for 2 purposes. I'm all about that in the OSCE. So other care plans you could write, so obviously pain, patients presenting pain, again, very easy, straightforward care plan to write. You could write one on shortness of breath, and you could also write a care plan around providing a dignified death or supporting Craig with his wishes in his end of life care as well. For implementation, the end of life medication chart is relatively simple and straightforward. Normally there's analgesic in the forms of paracetamol, so very familiar analgesic for you. And then there's normally some as required metoclopramide. This is for nausea and vomiting. And this is a common area of fail in this station because remember, it's an as required medication. So there won't be a time. So you will give this medication if the patient is feeling sick or nauseous. And in order to know that, you have to ask your patient if they are feeling sick and nauseous. And a lot of the time, nurses get this part of the drug chart, see there isn't a time, verbalise this as medication is not due at their time, and get failed because you have to ask the patient, remember there's no time, it's an as required medication, you have to ask the patient if they are feeling sick and do they want their anti-sickness. And most of the time your patient will say yes to those questions, or you are expected to administer that metoclopramide. Other medications that might be on the chart might not do at your time. So obviously laxatives because the patient's constipated, senna, sodium doxycycline. There might be some PRs, suppositories, and phosphate ethers as well. Again, you know, if they're not due at your time, you just verbalise they're not due at your time and they've already been administered. And there might be the opioid analgesic as well. So oxycodone hydrochloride, for example. So this is an opioid medication. It's a controlled medication. You wouldn't be getting it out in your medication station, but it would be on your chart. But again, if the patient's got very severe constipation, we would be looking maybe for a temporary alternative medication, possibly. So just be aware of those. There might also be medications such as enoxaparin, so the DVT prophylaxis as well on your chart. Again, shouldn't be due for your time. You're not going to be administering that in your OSCE implementation station. So just be clear to verbalise it's not due at your time. Going on to evaluation recommendations. So it depends on your scenario. You might be handing over to a nurse, you might be handing over to the community team, the patient might be going back to the community team, you might be handing over to the next nurse on shift. So always just think about in your recommendations of your evaluation about ongoing continuity of care. So if you were not to see this patient again, would everything be handed over? So safe care and continued care, what this patient needs will carry on. So again, thinking about the primary reasons constipation, so we'd want the outgoing nurse or community team to follow up on bowel assessment, so continue to monitor and follow up on bowel assessment. We'd want them to assess and review pain and analgesic medication, especially if we are altering that medication. We'd want to highlight and support the patient with any spiritual needs and as well. We might have done some follow-up referrals in our care plan, so maybe things such as Marie Curie or Miller nurses if required. And we want to make sure that we'll continue to provide emotional and wellbeing support and supporting the person with end-of-life wishes as well. Obviously, if there's anything else that comes up in your scenario, any physical observations that are a concern, or anything else that the patient voices, I don't know exactly what the scenarios are like, but obviously bring those into your evaluation as well. So I hope that's helpful. A little bit of an overview of the end of life scenario. It's not complex, okay? It's relatively straightforward. Don't be afraid to have open discussions with your patient around their wishes, their spiritual needs, their support during this time. That is really important. Remember to show compassion and empathy as well. Keep it simple, keep your care plan simple and relevant to your patient. And with your medication chart, don't forget to check that patient needs that as required metoclopramide, really common area of fail for a lot of nurses. So I hope that's helpful. Like I said, I do one-to-one tutoring, and that can be from a full package to just single sessions. So I get a lot of nurses just come and book in 2 sessions, practice their OSCE stations before they go off to exam as well. I'm really booked up though, so you want to be giving me as much notice as possible, because I am only one person, so there's only so much I can do. So I hope that's helpful. Please like, share and subscribe my videos, because obviously it really helps if you find them useful. Keep putting your comments in. I try and answer them best I can with the knowledge that I have. Sometimes I don't always know the answer, but I will go and try and find out for you as well. My details on the bottom there, hannah.lames@outlook.com, or my social sites, Facebook and Instagram, Nurse Tutor Tutoring with Hannah. Go over and give it a follow. Put lots of other useful information, especially on Facebook as well for you for your exam.